we get to hear from Dr. Harry Rosado Santos. I think I saw him over there somewhere. There he is. And we are going to get to hear from him. He's up here from Salt Lake. We get to hear from him about PrEP. So we'll be talking about a little bit about the HIV. So thank you so much, Dr. Rosado Santos. Let's give a round of applause.
So thank you for the invitation to come here and talk to you about PrEP. I hope everybody here knows what is PrEP. It's a term that we are using since 2017, an intervention to help people prevent getting HIV. And there have been some changes. I did this presentation maybe 3 or 4 years ago, but there have been new stuff added to the medications that we use to treat this, to manage this thing. So these new guidelines came in 2021, so during the pandemic, and there have been significant changes since the initial guidelines from 2017. So one of the things that I want to talk that is new is about an injectable medication that you can give to your patients every 2 months instead of taking pills every single day. And so let's just start. In the past, I think the last time I was here, I told you that we need to interview patients and find out if the patient have a high risk, through sexual encounter, IV drug use, that kind of thing. And that have been changed a little bit. And if you want to go to the CDC, there is an official document available for you to look at. It's extensive, but I'm trying to summarize those things. So again, back in 2017, the first PrEP guidelines were issued by the CDC, and now in 2021, guidelines were updated mainly because of the addition of this medication. The brand name is Apretude. Cabotegravir is the name of the medication. It's a medication that we are also using to treat HIV patients, and it's good because it's an injection every 2 months, and you don't have to come to you don't have to be taking pills every single day. So we are going to be talking about that. And there is going to be more medications. They're going to be approved probably next year, 2024, 2025, that we can use to prevent HIV, and actually injectables, and they might be actually given every 6 months. So when that comes, I'll be back to tell you that. So in 2017, there was this recommendation that if the patient belonged to a risk group like MSN, men that have sex with men, active IV drug users, sharing needles with somebody else, having a partner that is HIV positive, having multiple heterosexual encounters, that qualified those persons to, probably to get HIV prevention therapy. And I think at that time also I told you that some of us have hard time talking to the patient about sexual practices. I am not going to be talking about that here. I hope that in the future, if you didn't have one during this meeting, you should have one. I do that all the time, so it's easy for me to start talking about that with the patient. I don't know about you, but it's something important. Because of that, and sometimes also because some patients will not tell you exactly what they do, in the private setting. So the CDC changed the guidelines, and they decided that anybody that comes to you and asks you for PrEP, that person should have PrEP. It doesn't matter. They probably will not tell you, by the way, I have sex with men, or things like that. So all sexually active adults and adolescents should be informed about PrEP for prevention of HIV. That's a new thing. And they say that back in 2015, people who qualify for PrEP, we were able to to do that in 3% of the cases. But in 2020, now we had 25% of the so-called 1.2 million people that will benefit from PrEP. So we are we are gaining territory, and hopefully we will get, if we can get most of the people that need PrEP on PrEP, the incidence of new HIV cases is going to go down, and that's what we want in this country. We want to stop the transmission of HIV. It's a very expensive disease to treat. Basically, it's a lifelong treatment so far, right now, because we don't have a cure, but we have great medication to treat HIV. But you don't want to do that. You want to prevent PrEP. I treat patients with HIV. Okay, so when you approach a patient, I just had 30 minutes, so I had to go quickly. When you approach a patient about, I want to have, or I would like to have PrEP, I think you should do it. But if you are interested and the person is not talking to you about that, you should mention that, and then you start asking this question. Obviously, most of the time people are sexually active, not always. As if you had sex with men, women, or both. And just casually, you don't have to, just, hey, what is your sexual preference, men's or women's or both? So if the person say, yes, I am sexually active, and I have been sexually active in the last 6 months, you are going to ask, do you have a partner, a regular partner? Is your partner is HIV positive that you know about? Or you have multiple partners and you don't know? Maybe one of those partners is an IV drug user, things like that. And an important question, sometimes we don't think about it. So, well, by the way, like 3 months ago, I went to the health department and they diagnosed me with gonorrhea or chlamydia or syphilis. That's a clue that probably that person should be on PrEP. Is having unprotected sexual encounters. Locally, they got something that can be treated and cured. And also when they go to the clinic, to the health department, they do HIV testing when they do the gonorrhea, chlamydia, syphilis testing too. I have multiple sexually transmitted diseases in the last year. So that probably is a good candidate for that. So if I have an HIV partner and the partner, I don't know, he or she is not telling me too much, maybe it's a good idea for me to be on PrEP because you don't know, my partner is taking medications all the time. If my partner is undetectable, that means the HIV viral load less than 200. That's the official CDC number. We like to see that all the way to less than 30 or 20. And if the person say, no, that I don't know, so you need to talk to that person about PrEP. It's important. Believe it or not, I encounter many people in the clinic, they newly diagnosed HIV, younger people, and one of the questions in the initial visit, were you using PrEP? And some of them say, I don't know what is that. And that's a shame that they didn't know that. So if you have multiple sexual partners, most of the time they don't know if the partner is HIV positive or not. Are you using condoms or not? So if they are not, and they don't want to, that might be a good candidate. That person might be a good candidate for PrEP. If they say they are using condoms, condoms are 80% effective preventing sexually transmitted diseases, including HIV. So you might need to talk about that. And when they have sexually transmitted diseases, definitely, and they have sex with men, IV drug user, those are the people at higher risk of getting HIV, and definitely you should advise them to start PrEP. So, but at the end, if I come to you and I say I would like to start PrEP, you want to ask me questions, that's fine. If you don't, there is something that I have that I might not want to tell you, and I will, if I am you, I will start the patient in PrEP. After you explain what is PrEP and all that. So we have 2 medications right now that we use, Truvada, entristabine, tenofovir, and the Descovy, entristabine, and tenofovir alafenamide. The difference between the two, they are some different. Truvada was the first one that was approved. It can cause renal dysfunction in some people. So the guidelines will tell you that we need to do a creatinine clearance and a urinalysis and that kind of thing. Obviously, if the person had hypertension, diabetes, at higher risk of renal dysfunction, you have to be careful if you're going to prescribe Truvada. The other medication is Descovy. Descovy is basically the same medication, but when they developed that in mind, they kept in mind, okay, so what we are going to do is to try to minimize the renal toxicity of Truvada, so that Descovy came to the market for that. So I think the creatinine clearance for Truvada is all the way to, is it 70? So you have somebody less, creatinine clearance less than 70, you can use the SCOBY. But the SCOBY is below to 30, isn't it? 30. So if you have somebody less than 30, then you should not use, obviously, the SCOBY or Truvada. So that's an important thing that you need to do at baseline to know. They are very effective. Truvada was tested for IV drug users, MSM, transgender female and female patient, okay? And also Truvada is safe during pregnancy, so for you to know. The SCOBY was just tested in MSN and transgender female, a male that is now a female. So, but it was not tested in females. So the SCOBY should not be used in females if that is the person that wants to do a PrEP. Again, you have to do those two testing, the renal function testing and the medical history to be sure they don't have any condition that can make them have renal problem. Both are safe during pregnancy, but remember, the SCOBY should not be used in female subject. So it's a pill once a day, kind of there. The SCOBY pill is smaller, but you have to take it all the time. Either one, so when you take them in males, it will be 7 days, and you say you take it at day number 7, you have full protection for both of them. In females, it's actually 21 days. Just you need to tell them that, so during that time, it's really important that you use condoms. It's also really important that you keep using condoms because you want to prevent gonorrhea, chlamydia, and syphilis. These two medications don't prevent that, only HIV. And they are more than 90% effective if you take it the way you're supposed to, one pill every single day. So the new guidelines, the 2010 FTAF is the SCOBY. It's not recommended for people assigned a female sex at birth who could get HIV through resective vaginal sex. I mentioned that to you. It's really important. So the two of them, Truvada and the SCOBY, can increase cholesterol. So if you have a patient that had hyperlipidemia, but the patient is being treated already with a statin or whatever you're using, you should do a lipid panel at least once a year. You probably are going to do that anyway because the patient had hyperlipidemia, because this thing can increase cholesterol too. The creatinine clearance should be checked, every 6 or 10 months. Obviously, if you have somebody that have a borderline serum creatinine or creatinine clearance, not quite bad, I will do that maybe every 3 months. You decide that, okay? It's just don't follow the guideline. The guidelines is like a general thing, but every patient is different. If you have somebody with a creatinine of 1.5 or 1.4, diabetic, hypertensive, you might want to check it more frequently when they are taking this medication. So remember that before you start this medication, you're supposed to find out first if a person is HIV negative. This is only for HIV negative patients that might get HIV. If the person is HIV positive, then you refer the patient to the HIV clinic. So one of the new, in the past, they said just do the HIV testing, that is the antigen antibody test. That actually will catch HIV in the first 2 or 3 weeks. The older test takes longer for those tests to become positive. But they figure out something, that there is if I get HIV test today, if I get exposed to HIV today, it might be 2 weeks in the future for the antigen antibody testing to be positive. But before that, there is a test that I can have that will tell me that I have HIV, and that will be the HIV PCR viral load. That will turn positive first, increase the concentration in the bloodstream, and then it takes the body 2 weeks, 3 weeks to develop the antibodies. So right now, we want to catch HIV as soon as possible, so you should be doing the HIV PCR and the HIV serology antigen antibody. That's the test that you want to do, nothing else. Because if you catch HIV early, again, this person should not have Truvada or the SCOBY, and the person needs to go to the HIV clinic. Remember, liver testing is important. Adding to the liver testing, Truvada and the SCOBY also can be used to treat chronic hepatitis B infection, and we do that in the HIV patient. Locally, Descovy or Truvada are one of those medications that we use and something else to treat HIV. So it's happened that the person had chronic hepatitis B, then they are being treated at the same time for HIV and hepatitis B. And you need to know about that in your PrEP patient. If they have hepatitis B, chronic hepatitis B, that is going to treat them, but you have to be careful. If I take that for some time, and all of a sudden I stop and say, I don't need that, I'm going to get married, or I have a stable partner, and that kind of thing, and they stop, they can have a relapse of the hepatitis B, and they can develop acute hepatitis. So be careful about that and talk to the patient. Not to do that they need to talk to you if they want to do that, and then you talk to a hepatologist or a liver doctor about what to do in this situation. Okay, so the changes, we mentioned a little bit. In this situation is patients that are going to start or restart PrEP after not being on PrEP for 3 months. The injectable, they haven't used the injectable. So remember to do that HIV testing before you start again PrEP. And if non-reactive test and no HIV exposure prone event in prior 4 weeks, you can prescribe PrEP actually the first day. There is another thing about doing PrEP. I visit you today, and I talk to you, and you say, yeah, you're a good candidate. But that day, you need to do the HIV testing. You can do a rapid HIV testing in the office, but it is always recommended that you do the standard HIV test. So if the rapid one is negative, you can start that, but you need to take the blood for the PCR and the HIV antigen antibody. Don't forget to do that. Sometimes the rapid test is not as good, or it's about antigen antibody, not about viral load. So it's important to do that. So patient taking or have recently taken PrEP, again, test using the HIV antibody antigen, and I will do quantitative HIV RNA or the PCR. You should do the two of them. And remember that for this patient that had been taking oral PrEP in the last 3 months, include patients who had cabotegravir, we will talk about that injection, in the last 12 months. So anybody who have been and now they are returning, you're going to do basically the same kind of thing that you do for new patients that never been on PrEP. So determining the HIV status for PrEP patient, not recently on oral PrEP, I am not going to go through that, it's a long thing. So you're going to do that test, the HIV antigen antibody and the PCR. So if you had a non-reactive negative and your HIV viral load is negative, then you can start using PrEP. If you had an indeterminate HIV testing, and you will be calling the clinic for that, sometimes you have the screen is positive, but when they make a difference between HIV 1 and 2, you say, oh, that's negative. Most likely that person doesn't have HIV. The most common situation that I see in the clinic is a pregnant woman. Every pregnant woman should have an HIV test along with other tests that they have. But pregnancy per se can cause a false positive HIV screening test. If you do the viral load, it's going to be negative. Okay, we are going to skip that because I have short time here. So remember, HIV tests in person who acquire HIV while taking PrEP differ from performance in person not exposed to antiretrovirals. The thing is this. So if I am taking PrEP, and then I don't take it all the time. So there have been times that I don't have enough blood concentration, and I get HIV, and I keep taking PrEP. If I have an HIV testing, but the next time I see the doctor, it might be negative because Truvada or the Descovy are going to delay the serology from becoming positive. So, but if you do a PCR, an HIV PCR, the PCR is going to be positive, quantitative or qualitative. So it's important. They say here that there might be a delay between a month or 2 months in HIV antigen antibody production, but the HIV RNA, that's what I just said, is going to be seen early. So you're going to do both tests, okay? And that's what you do. We are doing that when patients return every 3 months. We are doing the HIV antigen antibody and the HIV viral load. So these are the laboratory that you can look online. I think this presentation is available to you. Remember about the lipid, baseline, hepatitis B, the surface antibody, the surface antigen, and the core antibody. If I don't have evidence that I am immune to hepatitis B, please give me the vaccine for hepatitis B, Eplisab. There is only 2 injections, very effective. If I have hepatitis B, I am going to be in Descovy or Truvada, so that will take care of that, but I need to be advised by you that I have chronic hepatitis B and the things that I am supposed to be doing or not. Also, hepatitis A serology might be a good idea. Okay, the same-day PrEP is appropriate when you have all the ways to do the rapid test, if you want to do that in your clinic, but also you need to do the blood test, the official blood test, and send it, and you can start. Let's say that you do that with me, and then the next tomorrow or the day after that, my HIV test is positive. So you just call me, because I have been taking this COVID Truvada for a few days. It will not cause resistance, or it won't be a problem, but you need to get me back in care as soon as possible. And you're going to tell me, stop taking the Truvada for now. Hopefully you will going to call me to your clinic and talk to me in your clinic. Don't tell me in the phone, you had HIV, good luck. That's not a good thing to do. So let's see. Remember also to assess renal function. You might not need to know that right away, but you need to do that test the first day that I'm going to start taking Truvada or Descovy. Let's see. We also do, I am not going to mention that, but on the slides, like when I come to the clinic to see you, you're supposed to do an RPR, check me for syphilis, a gonorrhea and chlamydia testing, ideally a swab in your throat, in the rectal area, if I am an MSN. If I refuse that, then I don't do it, and a urine test. Because sometimes people can have, if you don't do, let's say, the urine only, but I got gonorrhea in my throat, you're going to miss that opportunity. The other thing, in the clinic, we see a lot of people who are positive for chlamydia in the rectal area or gonorrhea and the throat, and they don't have symptoms. They just are asymptomatic. And if we don't do that test, we don't know that they have gonorrhea, and they are going to keep spreading that. That is telling me they are not using condoms, and that is another opportunity for you to talk, hey, you should use condoms. That's as much as we can do, give advice to the patient. But don't be judgmental about that, because they might not come back to see you anymore. So we talk about a little bit about that. And there is a point-of-care HIV testing, but remember, you have to do the regular HIV test. Oral fluid, this is probably the most important thing about that. So the thing that you use in the oral mucosa to detect HIV, you should not use that one. It's just the finger, the drop, blood drop from finger prick. And remember always to do the creatinine at the first visit. And the other test that I didn't talk too much when you see the patient for the first time. Also, when you do this, it's important to know who is going to pay for the Truvada. Truvada is generic, and I don't know how much money is, but it's really inexpensive. Descovy is not, and it's really expensive. So you need to think about that. There is some, information, insurance that is copay assistant for people who had insurance. The copay will help. Doesn't apply for Medicaid or Medicare patients, just private insurance. And also, obviously, you need to have the patient know, you can call me, and I'm going to be calling you as soon as I get this test result. And the patient needs follow-up appointments. It's not like, I'm going to prescribe this and see you in 2 years. You have to see them initially every 3 months. If you figure out that the person is, is compliant, taking the medication, maybe we can do every 6 months. And remember the STD testing. So same day PrEP. So if you had a patient that is ambivalent, like this guy there, the patient is refusing to have blood tests for HIV, will not do that. The patient say to you, have you been okay in the last 4 weeks? And, well, I have fevers and large lymph nodes and headaches and a skin rash. It might be syphilis, but also it might be acute HIV infection. So wait, don't do that. If the person tell you, I have renal problem, but you don't have any test result, wait for the test result. Don't do it right away. And remember, patient without insurance, we do have a free PrEP clinic at the University of Utah. Everything is free as long as the patient proves that they cannot pay, that they don't have insurance, they don't have Medicare, Medicaid, don't have anything. So this clinic will take care of them. And let's see. So, but remember, we need to do an HIV test. It's not like, can you give me the prescription and I go tomorrow to have the HIV test? Well, I will say, no, I just had the test. Call me. I verify that you had the test, and then I can give you the prescription. And people who are probably mentally ill, other issues, homelessness. Because I am homeless doesn't mean I should not. But I have some homeless people that come to us saying, I lost my pills, somebody stole my pills. So that is a problem. So if they don't really take it all the time, it's not going to work. So, okay, so that is something that has not been approved in this country, just in case you are thinking about that, called on-demand. On-demand, these two studies, Hypergay 155 and the Prevenir, done in France. So they compared doing this 2-1-1 dosing compared to taking the medication every single day. And they did these studies only in the MSN population and with Truvada. And they found this, so that actually is a good regimen, again, for the MSN population. So you take 2 pills, like between 2 to 24 hours before you're going to have sex. They say closer to 24 hours is preferred. Any reason for that? So if I take it like 20 hours before my sexual encounter, the blood levels will be better by the time I have sex. If I take it 2 hours before my sexual encounter, I might not have enough in the blood. But they say 2 hours will be okay, but not less than that. So if I take it in an hour, I had to think, well, I had to wait before I engage for at least 2 hours, and then I can do that. So then 1 pill 24 hours after that sexual encounter, and another pill 48 hours after that. So that will be the 2-1-1 regimen. It's not approved in this country, but you might see some patient asking you about this. It's effective. It's not as good as the daily Truvada or the SCOBY. Remember, this have been studied only with Truvada, not the SCOBY. There is a telehealth. We sometimes do telehealth visit for PrEP patient. And we want to be sure that after the visit is done, obviously they are not going to have the swabs and the blood. They are supposed to go to a lab, and we encourage them to come to have the swabs done in the clinic. My experience is the laboratory will not do rectal swabs, or usually they don't have the swabs that you need to do this test. Remember, the swabs are for gonorrhea and chlamydia. You can do a 90-day supplies once you know that the HIV is negative for PrEP medication. So that means you want to see the person in 3 months, and you need to tell the patient, if you don't come, then I might not refill. What I do sometimes is if they miss that 3 months, I do 1 month, more months, and I say, you need to schedule in that month. But don't keep prescribing this medication without doing HIV testing. The patient might not be compliant, the patient maybe had HIV, but because they were taking Truvada or Descovy, they didn't have too many symptoms because partially that infection was being treated. So it's important. Now, the new thing that was approved is called Aptitude, as a brand name. It's cabotegravir extended release injectable suspension. And this is, again, the same rules that apply for Truvada and Descovy in terms of who needs PrEP, apply for Aptitude. This is not recommended for people who are younger than 18 years old so far. We don't have data about that. It's a 600 milligram, 3 ml of cabotegravir injected in the gluteal muscles. And there is a technique to do this. It's not like everybody. This had to be given in the clinic, in your office. The patient should not give this to himself or herself, or the patient don't have anybody else. Oh, I have a nurse friend that is a neighbor, and she can give this. No, it should be done in your clinic. It's really important to be sure that the injection is given in the right place. If you decide to do that, the company will send somebody to your clinic to give a training to the nurse or whoever is going to do the injection. Okay? So then you had the initial thing, 2 injections a month apart. So in 2 weeks, you get a second one, or one in a month, the second, and after the second, you get every 2 months. Almost there? Okay. And then there is these 3 milligrams daily of oral cabotegravir. The main thing when they approved this, initially this was approved for HIV therapy along with something else, another medication. But they say if you inject this right away and the person have an allergic reaction, that's a problem, isn't it? Because you cannot take out the injection, that thing. So they say, well, just do the oral for 4 weeks. The person doesn't have any problem, allergic reaction, that kind of thing, then and then start doing the injection, okay? It's just, also the other thing is just to test the patient, if the patient is going to follow instructions or not, and that kind of thing. But some people are doing injections right away, not doing the oral. You can do that. We haven't seen any patient with allergic reaction in the clinic, I think, so far. Remember, we also use that for treatment. So these are the trials telling you that cabotegravir compared to Truvada, they are good. Actually, if you can look, incident of HIV infection at the bottom, 38 patients in that study, 4 in the cabotegravir group and 34 in the Truvada. So it's definitely more effective. Probably, I think what they're telling here is having an injection and this medication going in your body for 2 months. Obviously, people cannot do like anything to miss the dose. The main thing is for them to come back to get the other injection. So it can be used in people with renal disease. This medication doesn't interfere with kidney function, doesn't do anything. So that's a good thing for people who have renal problem. The problem will be when you ask the insurance to pay for that, to cover that. It's a pain in the gluteal area. Also, people that you had on PrEP, but they are having problem, and you can figure out, well, I think the insurance will pay for this medication, so maybe you can switch them. So the disadvantage of this infection is injection site reaction. That's the most common thing. So for PrEP, let's see, how can I say this? So this medication, even though you get it every 2 months, the medication will stay in your system for a long time when they start decaying. So if I stop taking cabotegravir, the injection, and you're going to ask me, you need to be careful, condoms all the time, and that kind of thing. If I don't do that and I start having high-risk encounters and I get HIV, what is going to happen is that I will get HIV, but the HIV might be resistant to cabotegravir because I still had that in the bloodstream, but not at the concentration that suppress HIV. And this is a good medication that you don't want to, you want to use in the HIV population. And in that kind of situation, there is other that you can use, obviously, but that's the main thing. The person has to come to your office, and so that's the other thing. And some people had injection site reaction, headaches, fevers, fatigue, back pain, myalgias, and skin rash. Remember that if you're going to be using cabotegravir, it's a cabotegravir. You're not going to do cabotegravir and Truvada or Descovy. It's just that one. That's it. The study shows that it's effective. Remember, gluteal muscle is the only site that this should be injected. Home administration or administration by the neighbor or a shopping center should not be done, ever. And then if you are in oral PrEP, if you want to do this, so, you had to do cabotegravir only, and do not prescribe. The oral cabotegravir is only as an initial thing for 4 weeks. If the person says, I don't want the injection, then you need to switch to Truvada or Descovy, not oral cabotegravir. That's side effects. There is some things that you should do, but you don't have to check for the hepatitis. For the hepatitis B serology, I will check, because you want to know. Lipid panel doesn't do that, liver test or creatinine. So there is less tests. You should do the gonorrhea chlamydia thing. And this is going to be there. Let's just. So remember, cabotegravir was no data yet available for clinical trials in men or women to estimate when this thing is going to start working. I told you Truvada will be 7 days for male and Descovy and 21 days for female to be optimally. For this one, they don't know. So, but anyway, so use condoms all the time anyway. Pregnancy, we don't have too much data about that, but they say this is the only thing, and the anticipated benefit outweigh the risk the person can have that, the pregnant woman. And this is just reference guidelines about that. Thank you. Any questions about this? I know the last one, there's somebody else.
We got one more. Oh, we got a question for you.
Can you just review what the proper technique is for doing a rectal swab?
Well, you know, the throat is easy. It's just like you're doing a group A strep swab. You just go to the tonsil and swab. It's not a big deal. The rectal thing, so this is what I tell the patients. I ask them, you want me to do it or you want to do it? And if they want to do it, after I do, when I am doing the throat, the swab that I have a little notch in the middle. You're going to break it because the whole thing doesn't fit. So I just told them, you just put that in your rectal area, but not the whole thing. I am going to be, I'm sorry, I hope I don't insult anybody. It's a long thing, so just a little bit there, do this movement, take it out. If you see stool at the tip, that's good. That was there in the rectal area. Just put it in the container, break that where the mark is so it can fit inside and close it. There is some fluid in the container where you're going to put the swab. Be sure that you get the right one. And now the swabs, the government has approved the swabs for gonorrhea, for throat and rectal area. And the urine is just a urine sample. You don't have to do, they do a gonorrhea, chlamydia, non-nucleic acid amplification test for the urine sample. So you don't have to do females, a urine will be okay, or they can do their own vagina swab. We try always to do the three of them. And remember, some people can have gonorrhea in the mouth and the throat, but they don't know it. So we need to treat that because if not, they are going to keep spreading that. And also some people have this idea that oral sex doesn't spread anything. It does. People can get syphilis having oral sex and gonorrhea and chlamydia. So any other question about swabbing? And again, don't be afraid to ask the patient if you feel the patient is sexually active, maybe at high risk, maybe you had an idea. Just, hey, do you know about PrEP? If you don't want to talk about it, get some, written literature, just give it to the patient as part of the visit. Like, oh, we got this for you, and that's it. It's important for people to know that we had this prevention thing. To prevent a disease that we cannot cure, we can treat, but you don't want patients with HIV. So, thank you.